It is one of the only five collaborative centers all over the world, and the only one in our part of the world. The center mandate is to galvanizing healthcare regulators, payers, providers, patients, families, and communities around patient safety with the aim of providing healthcare services free from harm. The Saudi Patient Safety Center is an acting leading custodian of patient safety strategy with a focus on giving a voice to the community and healthcare providers. So, as we start our workshop, I would request Dr. Ali Zahid, who is the Director of Audit, to come and give the welcome address.
Assalamu alaikum wa rahmatullah.
Bismillahirrahmanirrahim. Respected Madam Professor Dr. Yasin Rashid, Health Minister of Punjab, respected Vice Chancellor, Fatma Jannah Medical University, Professor Dr. Amir Zaman, and my enthusiastic participants, Assalamu alaikum. I'm here to welcome you on the inauguration of the 4 days online workshop organized by the Department of Audit, that is Office of Research, Innovation and Commercialization, Fatma Jannah Medical University. I hope that you will enjoy this wonderful learning experience. And this workshop is organized by collaboration with the Saudi Patient Safety Center. Best of luck for your 4 days workshop. And stay blessed. Thank you.
Can you hear us? Can you hear us? Hello?
Yeah,
we can hear you. Oh, that's great. That's excellent. All right. Thank you very much, Dr. Abdulillah. So I would first introduce you before you come in and say a few words. So Dr. Abdulillah Al-Hasawi is the founding Director General of Saudi Patient Safety Center and the Saudi Ministry of Health Advisor on Patient Safety. He holds dual certified boards, both American and Canadian, of general surgery with subspecialty in transplantation, transplant and hepatobiliary surgery. He is a consultant to several nation and international quality and safety organizations and recently became an executive committee member of the Global Sepsis Alliance. He chaired the organizing committee of the 4th Global Ministerial Summit on Patient Safety in Jeddah last year. Dr. Al-Hasawi has helped introduce patient safety as a G20 priority in the 2020 during the G20 presidency of Saudi Arabia. Currently, Dr. Hasawi is part of the WHO Global Patient Safety Action Plan Task Force. So over to Dr. Abdulillah for your remarks, please.
Thank you very much, Dr. Hussain. Assalamu alaikum, ladies and gentlemen, your excellencies, our colleagues and friends in Pakistan and here in Saudi. It's what a great pleasure and honor to work with you over the next couple of days on such a very important topic, which is patient safety. Our two beloved countries go way back in collaboration in so many areas, and we're very much connected at so many social, societal, religious levels, and bringing also this collaboration in healthcare is something that we're very much honored to have. This time, with this global pandemic that is taking place, which is not just highlighting the importance of safety of patients, but also it brightly so highlighted the importance of the safety of health workers. So every one of you who goes out of their way on a regular basis to help patients, the WHO found out that this year's World Patient Safety Day's theme should be health workers' safety is a priority for patient safety. And we in the Saudi Patient Safety Center have a vision statement that actually says safer healthcare for all, and all is written in caps letters to highlight the interdependence of the safety of patients and health workers. So, on September 17th, I'm sure both your country and my country and countries throughout the globe will celebrate the second World Patient Safety Day, highlighting the interdependence between the safety of patients and the safety of health workers. So it is our pleasure and our honor to be working with you and starting this very exciting journey of collaboration to promote patient safety through this patient safety officers training. My colleagues in the center are going to be working with you over the next couple of weeks. And this is not just during the workshop, but please feel free to keep the collaboration, keep the conversation as we move forward. We view this and we look at this as a marathon, not as a sprint. So this is just the start of an interesting journey. And we look forward to a very exciting and interactive workshop, and we look forward to a very exciting and interactive partnership, between our two organizations, between our two countries in patient safety and beyond. So with that, I'll thank you again for your interest. I thank you for all your efforts to promote the safety of patients. And I look forward to a very exciting workshop, working with you and our colleagues. Thank you, and I'll hand it over to you, Dr. Hussain.
Thank you, Dr. Abdulillah. We are also very excited, and we are really looking forward to having a long-lasting collaboration. We have a lot to learn, and since you are the only collaborating center in our part of the world, and I think we are really looking forward if we could somehow the other, make the Fatima Jinnah Medical University as hub of the patient safety in Pakistan, and do what you do internationally. At least we'll start it locally within Pakistan. So with these words, I would request Professor Amir Zaman Khan, who is the Vice Chancellor of Fatima Jinnah Medical University, to come for his remarks.
Bismillahirrahmanirrahim. Respected guests who are at Saudi Arabia, Professor Yasmin Rashid, the Honorable Minister of Punjab, and the respected participants of this particular workshop. So we are very thankful to you for being a part of us today in Saudi Arabia, and we really look forward in the university for a very close collaboration in the coming days. We are very proud, as you have said, that the two countries and being Muslim brethren, we will inshallah work very closely. And the main aim is, as our health minister always says, that is in fact the health of the general masses which has to be taken care of, and patient safety plays a very important part in that. So I will be very brief, and I welcome all the participants, and I'm very hopeful that at the end of 4th day of this workshop, we will be much wiser, and the coordination between Pakistan and Saudi Arabia, it will benefit a lot as far as the patients in Pakistan they are concerned. So thank you very much for being a part of this today.
Thank you, sir. Dr. Yasmin Rashid is not just the health minister. She has been an activist and even a patient advocate, and she has attended, I know, WHO meetings and UN meetings as a patient advocate herself. So, when we started this patient safety campaign in Pakistan, a few years back, she was the one who was the first made as the head of the patient safety network, and we had our first meeting at the Pakistan Medical Association's office, where she was the president at that time. So she's a great activist, and I know that patient safety is quite close to her heart. I would request Madam Minister to come for her remarks. Dr. Yasmin Rashid.
Bismillahirrahmanirrahim. First of all, I'm extremely grateful to Dr. Ansari from Saudi Arabia for organizing this very, very important workshop. Patient safety has always been very close to my heart. One of the major problems that I used to face, because I've been working as a volunteer for thalassemics throughout my life, it's been 26 long years that we're trying to improve the life of patients with thalassemia, and we realized that when we gave them blood transfusions and we gave them other treatments which required intervention, many a times those children ended up with, because the blood was not properly screened or we had those problems, and they managed to get infection from the treatment. So the result was that rather than helping out the patient, we had further worsened their situation. And I think the important part is, I was explaining to, I'd just like to tell Dr. Al-Asawi that this is an institution that I graduated from long time ago, 1979. And then I taught here for a long time. And my assignment was here for 3 years as a professor also. Quite a few of the young doctors sitting here, assistant professors, associate professors, have been associated with us. And they all realize that patient safety is very close to all our hearts. The idea is, when you're looking after patients, you want to ensure that first we should do no harm to those patients. So patient safety is now become the priority of our government also. It has been made one of the priority points on the health policy that we have announced for Punjab. And this is the next 10 years health policy, in which we hope that we create an extremely safe environment for the patients. A provincial committee has been established, and I work as a chair for that. We are also very happy that we have managed to launch, patient safety friendly hospitals. And these initiatives have been taken in one of our 10 large hospitals in Punjab. And I'm very happy that Fatma Medical University, being my alma mater, has been spearheading all this effort, and has also spearheaded this effort by involving all the senior teachers and the junior teachers to understand how important it is to look after patient safety. This year, the Patient Safety Day, which is on 17th of September, will be basically dedicated to the health workers who have worked for COVID. I'm very proud of this fact today that, mashallah, Pakistan at the moment, with all the effort of all our medical professionals, our healthcare personnel, which includes the nurses, the paramedical staff, And of course, the government put in an extremely concentrated and an organized effort, which has resulted in a certain amount of control on the COVID virus. Particularly today, we can boast of that the number of fatalities have now come into single digits in Pakistan, and the number of patients being diagnosed every day have drastically decreased. Hopefully, inshallah, we are hoping that this would be good for Pakistan. But what is extremely important is that a lot of our healthcare personnel got infected by the COVID virus. We have at least 4 people sitting in this hall who have suffered COVID virus and have gone through the problems of it. So I think it's extremely important that this year we dedicate the World Patient Safety Day to the health workers of Pakistan, and particularly to the safety, which is extremely important. And then as I said before, that I am again extremely proud of this fact that Fatma Jinnah Medical University has taken up this initiative and is leading, spearheading this whole struggle to ensure that doctors and paramedical staff and nurses understand how important it is that as healthcare providers, we ensure that patients are safe when they are with us. When they come to our hospitals, they have a safe environment. When they're being looked after by the healthcare personnel, they'll be looked after safely. While going back from the hospital, they won't take any hospital infection back with them because we'll be looking after their safety. It's not one aspect. There are quite a few other aspects which I'm sure they're going to learn in the next 4 days. I was reading the program. It's a very comprehensive program, and I really congratulate the Vice Chancellor, Hussain Jafri, and I'm very grateful again to Dr. Al-Asawi that he has really made an extraordinary effort to show in this difficult time that through internet we might be able to, and through these linkages we might be able to educate people, and interacting between both factions would definitely be beneficial not only for us here, but definitely will be beneficial to all the people who are participating in the workshop from the Saudi Arabian side. So I'd like to just say in the end that inshallah, I'd like to officially collaborate with Saudi patient. I'll be very soon contacting the Saudi minister in this regard, and we'd like to set up a very I think we need to set up a collaborative program for the future so that we can constantly share ideas and strengthen the Muslim Ummah. I think it is time that we realize that education are actually the most important hallmark of any development in any country, particularly where the medical sector is concerned. So thank you again. And Dr. Asawi, I'm extremely grateful. Thank you again, and I'm very hopeful that inshallah, when the participants leave after 4 days, they will be very well versed about the importance of patient safety. So thank you again. Pakistan Zindabad.
Thank you, madam. And with this, Dr. Asawi, I hand over the mic to Ms. Sophia for a proper, inauguration of the workshop for the first session.
Hello, good morning, everyone. Can you hear me?
Yes.
Wonderful.
Yes, Sophia, we can hear you.
Thank you, Rakan. Thank you, Dr. Jafri. My name is Sophia Macedo. I'm the coordinator for the Patient Safety Officer Training Program in Saudi and beyond. Basically, what I would like to say is to welcome you all to this course. It's going to be an intensive, but I do hope you will find it a very fruitful course, and that will add into your expertise, which I believe you already have within the patient safety field. And as it was mentioned already by Dr. Usawi and other speakers, we can't speak about patient safety without talking about healthcare safety and healthcare workers' safety. And that's I mean, there's a big reason why this year, the Patient Safety Day in September, it's all about healthcare worker safety and how that it's important to achieve a patient safety culture in hospitals across the world. What we will do throughout this 4 days is to go through the main dimensions that a hospital or any healthcare institution really should be able to build in order to achieve what we call a high reliability institution, basically to say that we should be able to deliver what we're meant to deliver. So not just healthcare, we should be able to deliver safe healthcare. And so throughout the 4 days, you will be exposed to the most recent advancements in this field. I'm happy to have, and I would like to thank from now all the speakers and experts that have accepted the challenge to share their knowledge beyond borders. So not just in Saudi, but beyond that. So at the same time that you're happy to be with us, let me tell you that it's an honor and an absolute pleasure for us to be able to share our knowledge beyond Saudi Arabia and especially to your country. So Mr. Rakan, as probably you came across already, he's the basically the backbone of our course. He's our support. So if you need anything in regards to any technical issues or logistics regarding the course, he will be the one to provide you with that support. On my side, I want you to know that we have a whole team working with you and for you throughout this 4 days, of course, that you will have. And you can connect with us anytime, as Dr. Hussawi has mentioned. You can connect with us anytime if you have any concerns. Regarding the certification of the course itself, and in particular, you will go through a needs assessment exam within a couple of minutes. It's not an exam where you have to pass or fail, obviously. It is as it's called, a needs assessment. It's an assessment document, let's say. It's more for us to understand how much how much knowledge you have as a baseline. And then after the 4 days, as you could see on the agenda, you will then go through an exam, which in order to meet the passing score, you have to achieve 60%. And this will entitle you for the certification exam. But again, if you have any questions and regarding these details, you can always contact me and contact Mr. Rakan. And I would like also to take this opportunity to thank Ms. Shadia, which has been my great support while going through some challenges because of COVID-19. So without further ado, I will pass the word to Mr. Rakan, and he will take you through the needs assessment exam. Again, I don't want to call it an exam because it gives like this very big word, but it is not. It's just an assessment that I would like to have from your side before we take on the course. You will have around 30 minutes to complete that. And once you're done, then we'll kick off with the first couple of sessions for today. And we are very mindful about the time where we will have to finish at 12 p.m. sharp. So we'll all be mindful of that. Thank you very much. And once again, welcome to the Virtual Patient Safety Officer training program. And I hope you can take the best out of this course. Thank you very much.
Thank you, Sophia, and thank you, Dr. Abdillah, Dr. Yasmin, and Prof. Amr. Okay, now we will do the test, inshallah. You can read the barcode from your computer or your mobile phone. Just if your device is Apple, when you open the camera and just take a picture for the barcode, we will read it automatically. If you use Android system, it should be download a barcode reader. If you have any issue, please tell me. It's clear what I say. Assalamu alaikum. The time for exam is finished. Now we will start the program. You can start, Sophie. Thank you.
Hello, everybody again. Can you hear me?
Yes, we can, Sophie.
Okay. So in order to make sure that we have no issues with, our sessions, if there is on the Pakistan side, if there is anything that you didn't understand or it was too quick or you missed some information, please just let me know on either by calling my attention with raising your hand. I can see you. You can't see me as of now because I'm going to share my presentation, but I'll try to pay attention to any notes regarding that. Okay. So, Rakan, that's okay. Can I share my presentation? Thank you.
Sure, you can.
I'll just share my presentation now. Okay, are you able to see my presentation?
Yes, it's
Okay. Sorry?
You can see your presentation.
Wonderful. Let's get started then. So what is it all that we are talking about whenever we talk about the science of patient safety? So let me just tell you roughly what we meant to achieve at the session. So basically, we'd like to outline the major milestones within the patient safety movement. I know that some people might think or feel that this is kind of a new thing. It is not. Patient safety and the patient safety movement has been there for at least 20 plus years as of now. So let's just mention some of the milestones. Identify current patient safety trends and issues within the healthcare industry. And as you understand, as healthcare industry evolves, also patient safety issues evolve. With new technologies, with new approaches to healthcare, that comes also new risks that we need to be able to identify and to prevent from causing harm. And what are the skill sets that we need to build when we want to have patient safety officers in our institutions? So let's say that you are a manager or a director, or even yourself, you want to become a patient safety officer. What are the skills that we need to look for when trying to build someone for this role? So the history of patient safety, as Dr. Yasmin mentioned and very well on her speech, patient safety, it's above all about not doing harm. And this was first said for those of us that have done the oath when we finished our degrees, either nursing or medical degree. The Hippocrates oath, the first statement says, first do no harm. So I think we all agree that we are in healthcare because we want to save lives, we want to look after people, we want to treat people. However, before we step in a hospital every day, before we aim at curing and treating and saving lives, we should be looking at first to not harm. And this is very important, that we should be we should be able to have in mind at all times. So for those of us that are either in the medical field or nursing field, I dare to say that we recognize this lady. Her name is Florence Nightingale, and she is known as the founder of nursing. And why we say that she has left us with a real legacy. So Florence Nightingale, she was a revolutionary person within the public health field. This picture you see here on your right side of the screen, we can say that it's on one of the first graphs that was built having statistical principles in mind. So, and this happened during the Crimea War. So basically, Florence Nightingale, as you know, she was a nurse, and she was looking, all her work was really within the battlefields of the Crimea War. And she decided to represent graphically what were the major causes of death among the military, the army. And usually we would think that people, the army, because of the work they were doing, that they would be dying out of, injuries related to the war, blood loss, amputations, and things around that. However, as you can see in this graph, the army was dying not out of battle-related diseases, like you can see on the orange part, but actually they were dying of non-battle conditions, meaning that the army was dying out of, in this particular situation, out of hospital-related infections. So basically what she was telling us is that as much as we were trying to help them with the conditions they were coming in, which were battle-related conditions, that actually we were overlooking things that were actually killing them, which was hospital-related conditions. So this was the first time that we thought about, how safe are we looking after our patients. And then the patient safety movement moved on, and this gentleman, Lucian Lee, he was a real, and he still is a reference within the patient safety field. So, and the reason is because back in 1994, he used to say that for us to move from an unsafe institution to become a safe institution or a reliable institution, we should be moving from focusing on individual reliance and go and move up into system reliance. And only then we could talk about reliable performance. What does this mean? It means that we know that errors occur in healthcare, that it's something we can't deny. They do happen, and we have to acknowledge that they happen. And then how do we minimize those errors? Because they will always be there. But how do we minimize them, and how do we ensure that they don't become, they don't cause harm to our patients? So to minimize these errors, we have to move from relying on one person's performance to relying on a system's performance. Dr. Moussaoui used to say quite often that each system is perfectly built to achieve the outcomes that it achieves. So as much as we may feel or think that we have a safe institution, if we see that the outcomes don't reflect that, means that we actually build an institution that allows for that to happen. So it's not about one person, And this is something you will hear quite often throughout this course. When we want to change patient safety culture in institutions, we have to move from relying on one person's performance and move to and assessing what is the performance of the system where those people practice and where people are looked after. And once we do that, the result will be a more reliable performance of everybody. So I'm sure that you are aware of the first formal report, let's call it, that was released in 1999. And this report was released by the Institute of Medicine, the IOM report, it's the reference, or many people see it as the kickoff report that had shed light on the real issues around patient safety around the world. So the beginning of the modern patient safety field is the Institute of Medicine report on medical mistakes. Its formal name is "To Err is Human," and this was the report that came out in December of that year. And this report basically used data from a Harvard study that was released 10 years earlier. And basically what it did the extrapolation and came out with an estimate that between 44 and 98,000 people die in the United States every year from medical mistakes. Now, remember that this was back in 1999. So those numbers today are way different and they are way higher. Now, if this report has ended with rather, shocking statistic, it would probably have stayed there. It would have gotten some attention, I believe, but otherwise would have gone away without, numbers are numbers and people tend to really forget about them. However, what the authors of the report did was very intelligent, and they used a very good metaphor where basically was a game changer. So we would never forget about the way they compared. So they basically said that the number of people dying out of medical mistakes back then in 1999 in the US was the equivalent of a jumbo jet crashing every day. And that analogy was really what galvanized and launched the modern field on patient safety. Now, this picture here is, I haven't chosen it, just, it wasn't just a coincidence. This picture actually relates to one of the worst accidents in the aviation industry that have happened with the crashing of two airplanes. Hundreds of people have died in this accident, and the aviation field have changed completely their approach to safety after this accident. So how many people do we have to have dying within healthcare? So we also change our game and how we do things. Now, how did the world look back when this report was launched? So the gentleman you have here in this picture, as you can recognize, is Bill Clinton. And the reason why he's here in this slide, it's because the IOM report was launched when he was the president of the United States. So how did healthcare look like when he was a president, and also when the report was launched? So quality and safety of healthcare was assumed to be perfect or excellent. There was no really a business case to improve safety and quality. I mean, if you think that everything is going well, why would you try to change it, correct? And not really local expertise or research or best practices were available at the time. And again, there was little concern by the board and the C-suite members or physicians and other healthcare professionals to improve quality and safety. So having this in mind, what happened next? So next we had another report being launched by the same institute, the Institute of Medicine, in 2001. And basically, the title of this report was called Crossing the Quality Chasm. So what is the chasm that we want to cross? So it's a divide between the current healthcare and what healthcare could be like. So in this report, they've defined healthcare quality in 6 parts, which I'm certain you're familiar with. So the first one said that healthcare should be safe, should be effective, patient-centered, timely, efficient, and equitable. The safe part is really what we believe everything falls under. If you have to be a safe healthcare, means that you've met all the other 5 dimensions. So this is very, very important. Now, what is the magnitude of patient harm? I mean, we're wanting to talk about patient harm, but what is the magnitude as of today? So adverse events that are happening due to unsafe care is likely to be one of the 10 leading causes of death and disability across the world, okay? Also, 1 in every 10 patients is harmed while receiving hospital care in high-income countries. So this is particularly important because if 1 in 10 patients is harmed in high-income countries where we believe that healthcare it's safer, one can only imagine how this number can look like in low and middle-income countries. A study also on the frequency and preventability of adverse events across 26 hospitals in 8 low and middle income countries showed that adverse event rate to be around 8% or 2/3 of the adverse events. And these result from unsafe care, and the years lost to disability and death occur in low and middle income countries, okay? Also, there is a high cost spent treating the effects of patient harm. So at least 1 out of every 7 Canadian dollars is spent treating the effects of patient harm in hospital care. In addition, unsafe medication practices and medication errors harm millions of patients and cost billions of US dollars every year. So as you can imagine, when a patient is harmed, it's not just that patient that is harmed, it's the whole society around him. It is harmed because of all the consequences that happen socially, economically, and even related to trust, okay? So when someone it's harmed within healthcare, the trust that we get from our patients starts to decrease. So it's not just about a number, it is really a global burden that we need to tackle. Now, this was part of a workshop that I just wanted to, I'm going to try to do it in a way. So let's look at this graph, okay? And in this graph, you can see the number of dailies annually worldwide. Okay, so it's regarding about I don't know how knowledgeable you are on epidemiology, but basically it's the disability associated with harm and life years lost related to diseases, okay? So each bar corresponds to a specific global disease or global condition, and certain conditions kill more than others. So you have 5 here, 1, 2, 3, 4, 5. Each bar corresponds to a global condition that causes disability years of loss of life. So I want you to take 1 minute to try to match what do you think this is related to, and where do you think patient harm it is located. So which bar do you think refers to patient harm in relation to other global conditions? You can type it on your on the side so we can have an idea, and then I'll show you which one represents what. Okay. Did you understand the exercise I was asking you to do? Do you want me to explain again? Okay, so basically, what I was asking for was oh, sorry, I guess I was muted and I didn't realize that. My apologies. So basically what I was trying to get from you is each bar on this graph represents a condition that kills people, okay? So could be cancer, could be diabetes, could be hypertension. And what I want you to try to do is which one of these bars, so the condition in bar number 1 kills more people than the condition in bar number 5, right? And this is how it works. So which bar do you think that is related to patient harm? And which condition do you think represents number 1, and which condition do you think represents number 5, for example? Okay, so I have a guess. Number 2. Okay, let's move on, and so we have a clear picture of how this graph. This is how it looks like. So this was a graph that was developed in released in 2015, which I believe that perhaps right now things might have changed a bit. But right then, what was happening was that adverse events were disabling and killing more people than malaria was and than tuberculosis were. And we were quite close to HIV and road traffic injuries. Now, as of now, I can tell you that patient harm related to adverse events actually disables and kills more people than HIV does at the moment. So this is a very powerful graph. And when we put things into perspective to other global conditions, it's when we really realize how big it is, the burden around patient harm. So this is also a very interesting graph. Oh, sorry. Oops. Yeah. So this graph is something that I just wanted to show to also put into perspective. So the blue line refers to the number of people that were dying out of COVID-19. Okay, and this was the number we had from January to June. Okay, so and the orange line, as you can see here, it's the estimate number of people that were dying on the same day that were dying of adverse events. Okay, so as you can see in this graph, we had more people dying of adverse events by June, adverse events related to patient harm, than we had people dying of COVID-19. So as you can see, this was the explanation of the graph. Now, how many people actually die of patient harm caused by errors in healthcare? So as per WHO, and that was reported also by the United Nations, a minimum, and I want you to keep in mind, this is a minimum number globally that says that 5 avoidable deaths occur every minute in the world, and this calls for urgent need for action on patient safety. So if we think that 5 people die per minute because of an error that we weren't able to prevent in healthcare, think about, today we have started the course an hour and a half ago. So if we want to do some math, you can calculate the minimum number of potential people that have died since we started this course this morning out of patient harm. Why should we invest in patient safety? Well, there is 4 dimensions why we should be concerned about this. It's the legal dimension, the financial dimension, as we mentioned earlier. There's financial implications every time that there is a patient harmed because of healthcare. There is ethical considerations. So in an industry where we aim to do good and to do no harm, you know, we are still causing harm. So this is a very important piece. And reputational as well, as we mentioned. As we move forward and as these errors continue to happen, people lose trust within healthcare, and this affects how we are looked by society and how people trust on the care that we provide to them. This is just some reference to also some milestones within the patient safety movement field. Back in 2003, the Joint Commission for Hospitals Accreditation have launched the worldwide patient safety goals that I believe we're all very familiar with. So this is just some reference to bring us back to when this whole started. So what is new within the science of patient safety? So we have new concepts such as the science of error and causation, system thinking, complex systems, human factors, cognitive psychology, applied informatics. These are all terms that you will hear throughout the course, and it will be important to really have a clear understanding on about patient safety. It's about new attitudes as well. If we want to change the safety culture of an organization, we have to change attitudes and behaviors. So it's not just about knowledge. It's also, and perhaps more importantly, about how we are within that institution as a person. So it's about teamwork, discipline, professionalism, a balance between no blame and accountability at the same time, and disclosure as well. So also about a new mindset. So we need to move from what went wrong to what went right. And this brings us to the patient safety 2.0, which is about looking at, we need to look at what went wrong so we can understand and change practices, but also we need to look into what went right and how can we replicate and enhance and shed light on things that are actually working, and how can we scale them into other institutions or other let's say moments of healthcare. And also it's about new skills. Okay, so those of us that are within the patient safety field have to have skills in error analysis. We have to have strong skills in leadership, change management, and lean theories as well. Now, think a bit on your own organization. So are you able to estimate the error rate in your organization right now? And are you able to identify current patient safety trends and issues within your healthcare system? So let's start from here and have this in mind throughout the 4-day course. Okay. So whenever you learn new concepts or you share your own knowledge, just also always keep this in mind. Like, think about your own organization. Think about, every day how many people are actually harmed, and if you don't have a clear picture of that, whenever you walk in through a healthcare institution, look around and think how harm can be actually happening considering the conditions we offer people right now. Okay, so whenever we see, let's say, a healthcare practitioner, not protected properly, or not communicating something properly, think about the potential for harm that can cause. Okay. Now, considering that we are on time, I wanted to open maybe 1 or 2 minutes just for questions, if there is any questions before we move on into the role of the patient safety officer. Are there any questions? If not, I will just move on into the next session about the role of the patient safety officer. Okay, so I will assume that there are no questions, right? I can see you on the camera, so if you just knock your head, so I can be assured that we are good to move on.
Can you hear us? Hello?
Yes, I can hear you perfectly.
Yeah, all right. Yeah, no questions from our side.
Okay, wonderful. I will just move on then. Okay, so this next session, I want you to keep in mind. Let's imagine that you are in charge of recruiting a patient safety officer to your institution, or that you already have a patient safety officer and you want to upgrade their skills, or you want to change the how or their what they should be doing. Or let's imagine that you are somebody that is willing to become a patient safety officer, and you wonder what kind of skills you should be developing. Okay, so how this role have emerged. So healthcare organizations have developed patient safety programs to obviously respond to pressures, both internal pressures of healthcare institutions and external pressures from society. So obviously, if you have a society and patients and healthcare practitioners asking you for safer care, then this is when you trigger the development of patient safety programs. Now, patient safety committees and or specific professionals are designated to lead the day-to-day implementation of a culture of safety. And because of this, the role of the patient safety officer was born. What I want you to understand, because this happens quite often, that the patient safety officer role, it's not just a title change. It's not somebody that you feel that has understands safety and has the let's say the willingness to do the job, and there you just go and change their title, and therefore you meet some sort of accreditation that asks you to have a patient safety officer. So it's not just about that. It is not a cosmetic change, as I say here, to an existing position, because it is based on an emerging cultural change, and like anything that has occurred in healthcare. So again, whenever you decide to assign this role to somebody, you can't just expect that, okay, it is a title that you have designated somebody, or even yourself, that you've been promoted and you became a patient safety officer. It's a way more than that. It's that person is responsible and accountable for a massive change in culture of an organization, not just a change in policies and procedures. It's a change in how we are in an organization, how we think, how we behave. It's the institutional culture change is on the hands of the patient safety officer person. The patient safety officer role and function has to be structured to achieve the goal of a culture of safety and not just a fulfillment of some regulatory or accreditation requirement, as I mentioned earlier. So what is it, a culture of safety? So here I am telling you that a patient safety officer is somebody that is accountable to change the culture of an organization to ensure that it's a culture of safety. So what is this, a culture of safety that we ask for? So it is, as per the definition, it is an integrated pattern of individual and organizational behaviors based upon shared beliefs and values that continuously seeks to minimize patient harm, which may result from the process of care delivery. So basically, it's a culture where everybody, starting from the doorman all the way up to the CEO of a hospital, that everybody believe and value it's first do no harm. And because everybody shares that belief and values, that we continuously seek to minimize patient harm, this is what builds a culture of safety in a hospital. So what skill sets are needed to build the model patient safety officer? So a patient safety officer person needs to have a global perspective of what? So a global perspective on the bigger picture of the interrelatedness of healthcare practices in that hospital. And why is this important? Because it is at these junctures or hands-off between departments, between entities within the hospital where the risk for patient injury remains the highest. So a patient safety officer really needs to understand how these transitions of care happen throughout an institution, so he understands the high risk for patient harm that may happen in those moments. Communication skills. So the patient safety officer must be able to clearly articulate ideas and concepts in a non-judgmental and non-confrontational ways. Integrity. So the integrity of the patient safety officer is critical to maintain effectiveness and build the trust essential to the new program in healthcare complex environment. Corporate honesty and transparency are also difficult concepts to implement unless there is a basis of integrity and trust. So if I can tell you that a patient safety officer should be somebody that everybody trusts. So he has to be a trustful person that remains with integrity at all times in everything they do. They have to have fluency in data. I'm not saying that should be somebody that is fully expert in statistics. We can have somebody dedicated to that, and this person can oversee that. However, they have to understand what they're looking into in front of them. So leadership and change management. So this role calls for leadership and team building skills. Also, a knowledge base, so a current understanding of patient safety theory, methods, standards, and regulatory requirements is essential, along with a commitment to lifelong learning to maintain expertise in a rapidly changing field. I was just not sure whether there were some questions or not. Okay, let's move on. The patient safety officer is uniquely positioned to an exposure of wide-ranging information sources in an organization. And because of this, they are one of the best people to identify risks, to educate and train, to avoid risks, to be part of root cause analysis, failure mode and effect analysis. And if you're not aware what this is about, you will know throughout the course. And they're also well positioned to manage and measure performance to reduce risk through benchmarking, claims, and loss of data. In enhancing these PSO skills, it is critical to effectively change the culture of safety and therefore reduce the risk and improve patient safety. So in brief, how can PSOs support healthcare institutions? So they support healthcare institutions by not harming patients. So this is when we talk about patient safety, by maintaining a safe environment for staff. And this is when we speak about workforce safety. And this is this year one of the most important themes within patient safety. And somehow the world has finally recognized that we will never be able to achieve patient safety unless we are very mindful of the safety of our workforce. PSOs will also support institutions to become financially responsible, so also leading to financial safety. So if you have less errors or less harm caused by errors, you won't be threatened with a financial burden related to treating those errors, and therefore you become financially safe. Also, you are, whenever you have a patient safety officer, you'll have support in meeting the standards and regulations. So it's when we called about regulatory safety and maintaining a favorable, trustworthy public image. So this is when we speak about reputation safety. So again, patient safety, it's not just about patients, it's about patients and all the dimensions that are at risk whenever an error reaches a patient and causes harm. And by having a patient safety skilled officer, you will be able to tackle all these 5 dimensions that are intrinsically related to patient safety. So how can we, have a patient safety officer role depending on, what kind of organizations are we looking at? So these are some examples. So in some in small hospitals, you can have one individual that it's wearing several designations, including patient safety, quality improvement, case management, risk management, and even infection control. But I want to call your attention to, this has to be very, very small organizations, because otherwise this one person cannot be pulled into all these different roles without affecting some of them. So this is really specific to very small institutions. Some other organizations, they can have a committee that is responsible to fulfill the requirements of the patient safety role. And larger organizations, which is probably what we should be aiming for, they have a dedicated patient safety officer reporting to the board or the C-suite. Any organizational approach can be effective or non-effective depending on the support given to the assigned PSO. Again, it doesn't really matter whether you have one patient safety officer or you have 10 patient safety officers within your organization. The point here is whether they're supported or not. If they are supported, you can be sure that they will meet what you assign them for. If they're not supported, then it's going to be very, very difficult, if not impossible, for your safety of culture of safety to change and your patient harm to decrease. So the patient safety officer person needs to be integrated with all accountability programs, such as quality, performance improvement, risk management, as well as medical staff, nursing, and other departments in the facility. And there should be direct, and this is very, very important, communication links between the PSO and all these entities. One critical and ongoing responsibility of the patient safety officer is to inform and assist the senior leadership to understand that their active commitment is essential to the success of the patient safety program. So this brings us back to what I was saying. A patient safety officer person needs to, in one hand, have full support of the leadership of that institution, and program. Let me just, okay. Okay, someone was saying I was muted. I think Makia. Can you hear me now, Makia? Wonderful. Great. Okay. So as I was saying, having the active commitment and support from the leadership, it's, I can say, the most important aspect we can have for a patient safety program to be successful. And those of us that, or those of you that are leaders in institutions, you may wonder, okay, what does this commitment look like? How can I, as a nurse manager or as a medical director or as a chief executive officer, be active, committed to patient safety? So what does entail? So entails total staff involvement in the patient safety program, entails a defined program plan and objectives for patient safety, ongoing support for a culture of safety. It entails to provide dedicated resources for required training, technology, personnel, and other program needs. It entails incentives for behavior that improves patient safety, and entails willingness to make difficult decisions, because there will be difficult decisions, and oversight of program progress by key committees and the governing board. So, we can't aim to have a patient safety culture and not have dedicated resources and dedicated staff and dedicate ourselves to it. The barriers, or the main barriers for this level of commitment, most of the time include competing financial priorities, meaning that, there will always be something more important. So this is something that we have to bear in mind. There is nothing more important, or there should be nothing more important than patient safety, even when we think about financial components. Remember that if you don't tackle patient safety concerns within your organization, financially will never be safe. Then also the fear of increased malpractice litigation and the resistance to change and misunderstanding of the nature of human error. So we have to understand that, as the report in 1999 said, to err is human, and we are humans, and as long as healthcare is being provided by humans, as long as this happens, or it's a reality that is there, and we have to be very mindful of it and not pretend that it doesn't happen. What we need to be focused on is on how to minimize that error, and mainly how to minimize the impact of that error into a patient, and how can we catch those errors before they reach to the patients. So, and again, whenever someone is involved in an error, we have to shift from blaming that person into looking at how is the system built, and how was this allowed to happen? Because if we just focus on that person, today is that person, but tomorrow it's going to be somebody else, because then the reason why this error keeps happening hasn't been tackled. So this is where we need to understand. So why should organizations have patient safety officers? So most of the time, one will look at the need for a patient safety officer for the first time when they come across external requirements for accreditation, for example. But it has to be more than that. Okay, and then so it has to also be around management of organizational workload when it becomes too heavy for people to handle patient safety workload, and perhaps this is the time when you realize, okay, this is the time where I should have one dedicated team to look into this. And don't take me wrong, I'm not saying that patient safety is only the responsibility of that team or that person. It is not. What it is the patient safety officer person will oversee all the activities and really try to implement the best strategies to change culture. Once this is done, everything else will be in place for practitioners at the front line to be able to provide safe care. And also because of the reduction in costly errors through loss prevention activities and mitigation of damage to an organization's reputation through the creation of that patient safety program. What sort of educational pathways usually a PSO usually has? It's not necessarily just this, but most of the time PSOs will come from risk management fields, from quality management, from nursing, from medicine, and other healthcare related backgrounds. So in a nutshell, the bottom line of the organization and the individuals providing healthcare services to patients and their families is, first, do no harm. And this is as true for everyone today as it was for Hippocrates centuries ago. Now, what skill sets do you have or need to be the model patient safety officer? So this is the question. I hope I was able to provide you some guidance or some light on that role. If you have some questions, please let me know. We are ahead of schedule, as I can see. Let me just double check. Yeah, we are. So we should, by the schedule, we should be going on break in 20 minutes, but actually we just finished this first part now. So I'm going to open to questions or comments. You don't have just to have comments, questions. You can have comments. The beauty of having this workshop when we do it face to face is that we're able to share experiences. We're able to say, this is how we do it in my organization. This is how we are planning to do it. And I would be very happy if you'd like to share some of your thoughts, some of your experiences. What kind of patient do you have? Patient safety officer roles within your organization. You don't? Does this make sense to you? Do you have? It is something you're aiming to develop. Please feel free to either by typing or just coming forward and just talking. As I said, I can see you on the screen, so feel free to come up front and share some of your experiences if you feel comfortable to do so.
Hello.
Yes.
Hello.
Yes.
Can you hear us?
Yes, I can perfectly.
Okay, that's great.
Hello. I'm not sure if someone was making a comment or a question. I couldn't hear because it was from far.
Hello. एक second. वीडियो आ रही हमारी जा रही Can you hear us? Hello.
Yes. Hello. Yeah, I can hear you very well.
I wanted to ask that what are the criteria for becoming a patient safety officer? Are you offering some training courses? Who can become a PSC?
My dear, I'm really sorry. I can hear you. I can hear you talking, but I can't understand, and I think you have the microphone. I don't know how far you are from the microphone or not.
Can you hear me?
Yes. If you can write it or repeat your question, please.
Can you hear me now?
I do, yes.
Okay, I wanted to ask that you have written a long list of what the PSO should do. So
Hello, can you hear me?
Yes, we can hear you.
Well, wonderful. I think your connection was gone for a while.
Okay, ma'am. The question was that there's a long list of what the patient safety officer has to do. So I just wanted to ask that are you offering some special trainings? Like what are the criteria for a patient? Any special courses? How we can become? Because it's a very
Wonderful.
job.
Okay, I hope I understood well your question, and it's a very valid question. Actually, we have, I mean, we have that question quite often. So it is true. A patient safety officer person has a long list into their duties and responsibilities, and this is why it is important that a patient safety officer person has to have a team with them to be able to perform with excellence of what they're meant to perform. In regards to certain skills, let's think about, for example, disclosure. It is something that it's very related to patient safety. We talk also about root cause analysis, or RCA squared, or even things like patient empowerment, facilitation, all those different skills. The Saudi Patient Safety Center, we can support in developing that with institutions that are wanting to. Usually, when we have requests, we are able to support institutions in developing training in those areas. So if there are specific fields or skills that one see that they need to develop, as I said, please feel free to connect with us and to let us know what your needs are, and we will try as much as possible to meet to meet the needs you're looking to fulfill.
Okay. Thank you very much.
Thank you.
Anyone else?
So if the group is okay, and if there are no questions right now, and I believe questions may, pop in later, you might be looking into your notes and wanting to clarify something that was said, please feel free to put those questions out at any time. As of now, as per the schedule that we have, we are meant to go for a coffee break and then come back for the last session around 10:30. Is that okay with you?
Yeah, this is fine. So we will take 22 minutes break now. It's okay?
Yes.
All
Yeah,
right.
and just to get things also organized, sorry, I just wanted to, because the next session on the system thinking, the last piece is the workshop called the Titanic. So usually what we do when we do face-to-face, we actually have a video that we streamline, and then we have a workshop around it. Because of, we're doing this virtually, and I won't be able to, I will try to see if we can streamline it, but I believe that it's not, it won't work. Then we will do it a bit different. And this to tell you that we might be able to finish a bit earlier than what it's on the agenda. Okay.
Yep, that's great. Good. So we'll be back in about 20 minutes time. All right.
Wonderful. Thank you.
All right. Thank you.
Thanks. Bye bye.
20 minutes.
Hi, everybody. I just want to tell you that I'm ready when you're ready.
Yeah, we are ready. This is Hussein. We just wanted to ask something. It's about the survey. Some of the people have not been able to submit the survey.
The one early morning.
Yeah.
Okay, they haven't been don't worry. I think Rakan is with us, so I'll just request Rakan to have a look into that. We could have perhaps on the chat, if we could know, or over an email to Rakan, who are the people that have not been able to, so we can sort it out.
All right, that's fine. And the other thing is that we will also send you the updated list of participants who are actually participating, because some of the people have not been able to come and some other people have joined. So we'll also send you the updated list of the people who have actually joined the workshop.
Okay, no problem. So Rakan can also, you will also look after that. So if you just communicate with him with the updated list, that will be perfect.
Right. Okay. Thank you. So we are in. So we are ready.
Okay, great. So as I said, we will definitely finish this section a bit earlier than scheduled because of how we usually run the workshop. So the last piece, basically, you will still do it, but you will do it offline. So Rakan will then send you the link of the video that we are aiming for you to see and to complete the exercise at your own pace at home, and then you will send the assignment back to us. Again, I will explain that later, but just to let you know about the schedule. So what are we going to cover now about systems thinking, design, and human factors engineering? So what is this basically all about?
We can't hear you. Hello?
You can't hear me? Can you hear me now?
Yes, we can hear you now.
Okay, wonderful. Okay, so what is this system thinking and human factors engineering session it's all about? So we will want to, by the end of the session, to outline the major principles around these two terms. Describe error causation, describe what are high reliable organizations to create improvement models that have been utilized outside of the healthcare industry, and how can we apply them into healthcare. Define human factors and system safety, discuss real healthcare examples, and for some reason, it's when you put forward stories that really happened that somehow it really clicks and makes us realize how important safety is. We will discuss how simulation can be used to understand errors and proactively mitigate them, and discuss some of the role of the patient safety officers. Well, not really discuss because we've already done it, but how to integrate their role into systems thinking and human factors engineering. So I introduce you again, Dr. Lucian Lee, and as I told you earlier, he is a reference within the patient safety field, and he used to say that errors must be accepted as evidence of system flaws and not as character flaws. What does this mean? It somehow supports or enhances what I was saying earlier, that it's not we can only discuss about or tackle patient safety properly once we move from individual reliance, and we move it from that into system reliance. So whenever an error happens, after Dr. Leap, it says that this is an evidence of a fault within the system, not a fault within a character of a person. So what is an error? So an error is a failure of a planned action to achieve what is intended to achieve. So you have a plan to achieve an outcome, and that outcome does not happen. So it's a failure of a planned action. So this is an error or a deviation between what was really done and what should have been done. So an easier definition, as I am putting it here, it says that an error is doing the wrong thing when meaning to do the right thing. And again, going back to meaning to do the right thing, it is important that we bear in mind that, you know, aside from some exceptions, no one wakes up in the morning wanting to harm anyone. So we all aim to do good to the best of our knowledge. However, due to circumstances, you know, errors will happen, and just the nature of being human will mean that errors will happen, and we just have to be able to understand how the system can change the chances for those errors to happen. I'm just going to ask perhaps for on your side, Dr. Hussein, just to mute, because I can hear a lot of my echo. So if that is okay, I would appreciate. Okay, wonderful. Thank you very much. So again, patient safety calls us to think systematically. And what does this mean? So basically, for us to think in a system way, so to have the system thinking approach, we have to understand first what's a system, so we can think like it. So a system is a composite of people, procedures, and equipment that are integrated to perform a specific operational task or function. A system has components, okay? And these components are interconnected in a way that will enable for a function to be performed when input is provided from a source, such as another component or human operator. So basically, as you can see in the picture, the system has people, procedures, and equipment that when they function in a very melodical way, in a very nice way, everything works to achieve the outcome that is meant to achieve, okay? So the reliability of a system, as we already mentioned earlier, it's the ability to perform its function over time under commonly occurring conditions. And you know, when we say high reliable organizations, what we're looking at are organizations that basically achieve what they are meant to achieve, which is safe care. And hazards are conditions or activities in the system that pose a threat of harm. And obviously hazards are the ones that can get in the way of reliability. Okay, so whenever we're trying to achieve a high reliable organization status, we have to be very mindful of what hazards are there that can be on the way to that, and then tackle them accordingly. How safe is healthcare? And it's very interesting, this slide, again, considering the year of the, I would say, you know, the 2020 is the year of the nurse and the midwife. I would like to think that 2020 became or just turn out to be the year of any healthcare professional because of the current situation we're going through. And somehow this pandemic showed us and put a light on how unsafe healthcare can be. It's not a new thing. Those of us that are on the field for a while, we are aware that healthcare industry is one of the most unsafe industries around the world. And this is when compared to things like bungee jumping, about driving or chemical manufacturing, aviation, railroads, nuclear power, constructing, mining, I mean, you name it. You think about a profession that is deemed as dangerous, think that healthcare is potentially ahead of that. Okay, so healthcare, it is one of the most dangerous professions that one can have. And why is it so dangerous? So the practice of medicine has become extremely complex. From the years, throughout the years, we saw, new medications coming forward, new technologies, new procedures, research findings that are coming to us in a very high speed rhythm, and because of that, this advancements in technology, the good consequences are that patients are living, somehow longer, but on the other hand, they are also living longer with complex conditions. So we are facing patients that are becoming increasingly complex because also they're living longer with multiple conditions at the same time. And also the diversity of the workforce is growing at an increasing rate. So all these factors are the perfect, let's say, the perfect mix for healthcare to become dangerous. Because again, for every new technology, for every new medication, for every new treatment or new approach of care, there are risks, new risks associated to it that we're not aware of them. And this is why it is so important that we keep track and we are up to speed when it comes to patient safety day by day. And so this picture basically just shows that the higher the complexity of a patient or a healthcare system, this equals to an increased chance of something definitely going wrong. So James Reason, if some of you are familiar with this gentleman, he came up with a concept of human error and within healthcare, and how does that affect patient safety, and what is human error and error causation, and the different types of error as well. And this is very, very important that you as patient safety officers, you understand those differences. So unsafe acts can be categorized as human error, okay? And human errors can be considered slips or lapse or mistakes or procedural violations, okay? And procedural violations is, when you know what the procedure says, and the deviation you make out of the procedure, knowing that you make that deviation. So it's like, in healthcare, we call it the shortcuts. So you don't mean to do something wrong, but you know that you're not following the procedure the way you should. Okay, so it's when we drift or blatant disregard for safety risks. Errors occur because of one of the two types of failures This is also very important to know. The action did not go as intended, so it's an error of execution. So, and usually this happens because of a slip or a lapse, and or the intended action is the wrong one. So the first one says that an error occurs because you did the right action, but it didn't go as planned. And the other way of failing, the other type of failure is the action you took was wrong from the beginning. Okay. Now, what is a slip? So this is just some terminology. A slip is selecting the wrong medication from a drop-down list, for example, in an automated medication list. Okay. A lapse is forgetting to implement a physician order in the desired time window, for example. A mistake or failure of planning that it's rule-based, it occurs when the wrong rule is applied. And as an example, it could be getting the wrong diagnosis and then embarking on inappropriate treatment. So basically, you diagnose something wrongly, and everything after that, it will also be wrong. And knowledge base is when the clinician does not take the correct course of action. As an example is when a clinician is confronted with what is for them new or a new clinical situation. So how when it comes from, when we look into error causation and how mistakes can happen at different levels, it is important that we understand that within healthcare you have the point of care, okay, where people are actually being careful. You have the line management, which will be your middle managers, your middle directors, and so on, and then the organizational top leaders. So at the point of care, the mistakes at this point, they are how to put this in a easy way. So it's where preconditions or qualities of human behavior and production coexist. So this the type of errors that happen at this stage, it's related to that. It's related to the patient that is in front of you and the clinician that it's in front of them. So it's a really direct connection that can cause immediate harm to patient and errors. Within line management, it's related to also to skill and knowledge level. Errors can happen due to work schedules. For example, if you have over workload staff and you don't pay attention, that some staff might be more overwhelmed than others, so mistakes can also happen to that. Technology, equipment, and maintenance programs, and attitudes and motivators as well. And at the organizational top leadership, it's related to decisions. So what's the root of a medical error? Usually at this, from the error causation science, we usually talk about the blunt end and the sharp end. So what is that we see at the blunt end that can bring us to an accident at the sharp end? So organizational factors can lead into errors. Local workplace factors that can also lead into unsafe acts that then can lead into accidents. So, for example, if you have an organization that does not have a policy on, let's say, maximum working hours by a nurse or by a physician, okay? Then if you don't have that policy in place, what's going to happen? Then it will be up to your local culture, your local unit that will, decide whether, you're working too many hours or not. And let's say that, you don't really have that culture in your unit, then it can lead to unsafe acts because, that nurse or that physician is working for too many hours and which wasn't considered by management, and therefore an accident can happen. Okay, and then the opposite as well. When accidents happen, then you look into what was the unsafe act that led into it. What are the factors and the culture that lives in that area that led into unsafe acts, and how can we change organization factors as well for that to be prevented. So perhaps this is a picture that you've seen often, and this is the Swiss cheese model. And basically what it says is that when you have, you throughout each slice corresponds to a, let's say, a chance for error, that if it's not stopped, it can lead all the way into a failure or an error or harm to a patient. So basically, there are triggers that you will see and you will recognize that can exist within your organization, that if not tackled properly, they will allow for a perfect error to go through all those holes and potentially harm patient. So, and those factors that you do have and we have, that we call the latent failures, you will definitely recognize in your institution that you have incomplete procedures, for example, regulatory narrowness, mixed messages. So communication is a big thing within patient safety. Production pressures, when we have to deliver very quickly. Responsibility shifting, so something is not right or something isn't clear and there is no one taking that responsibility, so they keep shifting responsibilities between people. Inadequate training, attention distractions, clumsy technology, and deferred maintenance. If we have all this well aligned, you will definitely have a bigger chance for errors to cause harm to patients. So, looking into this picture, what are the characteristics of a high reliability organization? So, what makes these institutions different from others? So there is a preoccupation with failure. Okay, these institutions, they search for their failures. They just don't wait for them to happen. They search for potential failures to happen so they can tackle them before they actually become a reality and harm patients. They are committed to resilience. So when something goes wrong, how do we move on? How do we learn from it? And sensitivity to operations. So they really understand how operations are conducted and, how can they go wrong or how can they go right, and how to fix and prevent error before they cause harm to patients. And they build and they maintain and they seek for a culture of safety at all times. The key principles for an institution to become a high reliable institution, it's to maintain a powerful and uniform culture of safety, use optimal structures and procedures, to provide intensive and continuing training of individuals and teams, and to conduct thorough organizational learning and safety management. So this is where other industries come into play, okay? Healthcare industry have and you know has and continuously learns from other industries. And as much as sometimes we can hear people saying that, you know, we can't just apply everything from other industries because healthcare is different and so on, truth is that a lot of the way we do things today in healthcare is related, it actually was learned from aviation and other industries. For example, the checklists that we use so much today came from the aviation industry and the military as well. So this is to say that, you know, we still have a lot to learn from other industries when it comes to safety. And when we say that the aircraft carrier, it's the prototypical, high reliable organization, let's say, it's because they achieve nearly failure-free record despite multiple hazards that you can imagine we have in aviation. Although healthcare is different from other industries, because again, people are not airplanes, we can learn that from their successes, what factors makes them, you know, make them work so well, and from their failures, how do disasters occur even in typically high reliability settings. So when it comes to controlling in the hierarchy of controls, so we can go from eliminate the opportunity for error, make it hard to do the wrong thing, make it easy to do the right thing, minimize the consequence of errors, and basically make errors visible, into policies, training, and inspection. And through, as you move up and down on those layers, you also have to include human factors into all this. And basically, what we want is to eliminate errors from happening, facilitate you know, doing the right thing all the time, and mitigate any risks that can be associated to potential error. So how do high reliable organizations reduce errors? So there are a few approaches, and we're going to go through some of them. So they do through simplification, standardization, avoiding a reliance on memory, improving access to information, taking advantage of habits and patterns. Actually, I was just reading something a few days ago on the taking advantage of habits and patterns. So there is this book that talks about rituals. So basically saying that if you are able to implement rituals within everything we do, we are less likely to commit an error. So that to me was quite interesting. Exploiting the power of constraints, enforcing functions, using visual controls to shape desired behaviors, promoting effective team functioning, teamwork, and effective communication is probably the most effective way to ensure safety within healthcare. Deploying redundancies, eliminating environmental factors that degrade performance, and creating systems that are better able to tolerate the occurrence of errors. So now I'm going to tell you or share with you a couple of stories, and as we move forward through them, I would like you to think about the cascade of situations that led to the adverse outcomes we will see in the stories, and the instances where better system design might have caught the errors. So in the first case, what do we have? We have a 35-year-old male. It's the first time he comes to see the doctor, and the purpose of the visit was to seek referral for ophthalmology. Following the visit, the doctor was reviewing lab results for a different patient, which showed positive fecal blood and anemia, suggestive of ulcer or cancer. The GI referral for the patient to GI lab for colonoscopy, and patient called the doctor questioning why he was tested for blood in his stool. At the time, it was identified that the patient had undergone an unnecessary procedure. So the patient was meant to go for a ophthalmology referral and ended up with going through a colonoscopy or just for blood on his stool. So on the second case, you have a 70-year-old female. She is an outpatient. She's going to go through an outpatient surgery for stress incontinence, fallen bladder, and prolapsed rectum. Vaginal packing was placed during the surgery and accurately accounted for the operating in the operating room. The patient went to recovery area and was to be discharged directly from there. The physician wrote an order to have the vaginal packing removed before discharge, but did not communicate that to the patient or to the daughter who was waiting. The nurse assigned to the patient was a male. He was working with a female nurse who offered to remove the Foley catheter and the packing, but she was interrupted and forgot to remove it, the packing, I mean. The male nurse assumed it was removed. The patient followed up with her physician 7 days later because of vaginal pain and gauze protruding from her vagina. This is the third case, a 50-year-old patient, history of GI bleeds and ulcers as a result of taking non-steroidal anti-inflammatory drugs. Patient was prescribed with non-steroidal anti-inflammatory drugs, and patient developed a GI bleed and had to be admitted for care. So, while we go through the three cases, what are the commonalities within them? So we can conclude that patients and family members who trust the healthcare delivery system will perform flawlessly. Practitioners with the best of intentions, with a commitment to do no harm, and can and do occur far more frequently than anyone in healthcare can admit. So we have to have this in mind in order to really move forward with a patient safety culture. So, we have patients that come to us trusting us fully, in a lot of cases without making any questions. And again, we do not wake up in the morning wanting to harm anybody. We all have good intentions to perform good. And however, we have to recognize and to expose that errors do happen more often than we'd like to admit, and sometimes more often than we know they happen. So it is very important that we are mindful that they do happen even if we're not aware of them. To change the outcomes of such systems requires us to think differently about the causes. Back to the three stories, let's think about what are the attributes of a safe, reliable system. Are the workflows very clear with roles and responsibilities that are explicit? Are mistake-proofing principles including standardization and simplification, obvious. Are there redundancies in place where needed to mitigate the risk of an error causing harm? Do team members share a collective responsibility for safe, reliable care? So think about these questions to the stories which I shared, but also within your own setting. Now, what is human factors engineering and human factor analysis? So human factors science, it's basically represents the intersection of psychology and engineering, looks at all aspects of a work system to support human performance and safety. So human factors science addresses problems by modifying system design to better help people. James Reason used to say, we can't change the human condition, but we can change the conditions under which humans work. So again, we know that our human condition tells us that to err is human. So as a human that we all are, we will commit mistakes. We will err, and we just have to be very honest with ourselves regarding that. Now we cannot change that human nature of us, but what we can change is to change the environment that we are in, so our human nature of committing mistakes does not affect patients and does not cause harm. Human factors engineering has been applied for many, many years into different industries, like, as we said before, aviation, oil and gas, railways, and nuclear energy industry. So within a systems approach, is the goal to eliminate human error? No. And the reason is human error cannot be eliminated. And the reason is because, again, human error is nature of us being humans. So unless we eliminate humans, which is not a possibility, we cannot eliminate human error. And if we say that in an organization, we are saying this is a futile goal. It misdirects resources and focuses. It causes culture of blame and secrecy because we know that it's not possible. And then we go into this mentality that we call name, blame, shame, and train. That's not what we are aiming with a patient safety culture, and not even with this, with this program. That's not what we meant to do. It is, yes, about reducing harm. So please bear this in mind. It is not about eliminating error. That's impossible. It is about eliminating the chances of that error to cause harm. So we're talking about achieving zero harm, okay? Human factors engineering focuses on humans and their interaction with each other and with products, with equipment, with procedures, and overall with equipment. How do we interact with the environment around us? Human factors leverages what we know about human behavior, abilities, limitations, and other characteristics to ensure safer and more reliable outcomes. And human factors engineers, they don't try to change the human condition, again, they try to change the conditions under which humans work. So it's not about telling somebody that you cannot forget to do this. Like, for example, you cannot forget to check the allergies of your patient because we are humans and potentially we will forget to do that. So it's not about changing, our forgetfulness aspect. It's about building systems that if you do forget, a system will remind you. So if you're completing a patient's charter, that when you have electronic medical records, if you're trying to complete the charting and you haven't added anything about allergies, the system won't allow you to do that without completing it first. And I mean, with this example, you have others. So again, it's about not redesigning humans. That's impossible. It's about redesigning the system within which humans work. So it's about redesigning hospitals that that will allow for high performance with reduced error, chances for error, and with zero harm. So the human factors SRK framework, basically, what it tells us is that regarding, for example, knowledge base errors, why do they happen if we think with this human factor engineering in mind, that improvisation in unfamiliar environments, it's I mean, it's something that sometimes we have to do, and unfortunately with this pandemic we saw that a lot. Nobody really knew how to approach this condition, so we had to improvise a lot, and not only that, but in unfamiliar environments, when you have crowded environments, like we did see in many countries, it's not just about not having the knowledge and improvise, knowledge to be applied, but also within which conditions are we doing this. No routines or rules available to help handle. I mean, there's nothing about routines and guidelines that we did have in the beginning of the pandemic. Rule-based, so protocolized behavior, process and procedures, and skill-based, automated routines required little conscious attention. And this is where slips and lapses might happen quite often. Like sometimes when I mean, those of you and myself as well that know how to drive, sometimes it's when you're so skilled in doing that it becomes an automated thing, and this is when most of the time mistakes happen, because you're not thinking about that anymore. You're just doing it automatically, and this is when lapses can happen, like medication preparation, any procedure that you are so used to do it, you've done it plenty of times, but this is when you have the higher chance of committing an error. These are just some examples. Packing and labeling, for example, from pharmaceuticals. I mean, I'm sure you've seen many situations where your packaging seems so similar for different deadly potential medications. And this brings us to a story from the quad twins and the medical errors. So the quad team story, it's he's a famous actor that had a situation where his two twins, or his twins, when they were born, they were in ICU, and in ICU, and basically there was a mistake where heparin was given to them, but instead of giving them the neonatal dose, they were given the adult dose, and not just once, but actually more than once throughout the same shift. When that story happened, actually the father, he didn't really try to blame the people involved in the case, as in the nurse, or they were actually blaming the company, the pharmaceutical, because the two vials are exactly the same. They look exactly the same. The only difference is a 0 within the dosage. So, I mean, this potentially harms, is an open door for an error and to cause harm. Thanks God the twins they didn't, nothing very bad happened to them. But I mean, you can imagine how far this could have gone if it wasn't tackled properly. Also, this is another situation. For example, if you are in a stressful situation, right, and you have this panel of the defibrillator in front of you, and when you have to, shock, would you shock the green or the red? Considering that red is usually a bad thing, we shouldn't touch red buttons somehow. And this is how we are built as humans. So how this environment here, so this panel here, can be built in a way that doesn't really, it doesn't really allow for an error to happen. So there was a lot of mistakes happening when people were meant to shock the patient, that they would touch the green button, and the green button would probably switch off the defibrillator instead of shocking the patient. So just because in our mind, green is good and bad is in red is bad, right? So let's focus on what the kind of let's say human errors that we can have. So what are the drifts that we talk all the time, and this brings us to the normalization of deviance. And the normalization of deviance is that you've deviated so many times from the procedural way of doing things that then it becomes the normal. So that's basically what it means. So it develops comfort with inherent risks and threats. So suddenly you are comfortable with doing things away from the procedure, because you are underestimating the risk of drifting from safety procedures, and you believe that the likelihood of harm is minimal. Continual reinforcement of underestimated risk supports continued drifting behavior. Okay, and when this and when it comes to keeping drifting and within your behavioral choices, you can divide this into in three different sections. So when you do something wrong with no intention, so it's a human error, so you didn't intend to, or and here it's where you have most of the slips and the lapses. And then you move into unconscious intent. So you did know that you were doing not the wrong thing, but you were drifting from the procedure, the policy, but you didn't intend to cause any harm, or you never thought it would cause any harm. And then you have the conscious intent, which is you knew what you were doing and you knew the risks you were taking. And I mean, what is the strength of behavioral incentives? So I will continue to deviate from the right thing, or I will continue to deviate from the guidelines if the consequences are weaker than the rules or other preconditions. If the consequences are uncertain, so you're not really sure what can happen if you do it that way, and all the consequences are delayed and not apparent. And the reason why it is so important that we look into human factors engineering is because, as I say here, our brain can play tricks on us. And I'm just going to show you some examples of that. So if you look into this, are the lines crooked or are they straight? So one would think that the lines are not straight, right? That they're a bit like, crooked or not aligned. Now, I can tell you that if we remove the pictures out, the squares out, you will see that the lines are perfectly straight, okay, and aligned. Now, if I ask you, and obviously I'm not going to ask you to do that now, but if I ask you to look at the chart and say the color of the word and not the word itself, you may have something playing in, you know, some trick going there, because you're looking at the color, but I'm asking you to read the color of the, so I'm asking you to tell me the color of the word and not what the word says. So, you know, it says yellow, and then blue, and then orange, but basically the color is different. You know, it's kind of, you have to say green and red and blue and yellow and blue, but you have red written. I mean, it's so why is it hard? It is hard because of the two main cognitive processes that we have, you know, in our brains. So we have automatic processing that leads into slips and lapses, like I mentioned earlier, and this can cause errors of execution. So you're doing the right thing. So you're planning in your mind to do the right thing, but you do it wrong. It's like, you know, when you're preparing medication, you're planning to do it right. And by, you know, because of interruptions or fatigue or time pressure or emotions or anxiety, fear, boredom, you are, I mean, you get distracted and you do the wrong thing. And conscious processing, problem solving leads to mistakes, errors of planning. So this is different. This is when the intended action, it's not the correct one. Okay. So this happens, you know, when we have an assessment of a situation that it's faulty, and you have the lack of knowledge. This was a video that usually we would show you, but we're not, I mean, I'm not able to show you right now, but it was just another exercise to show you how minds can trick us. So individual factors that predispose to error. And I think, you know, we all been through this, you know, limited memory capacity, further reduced by fatigue and sleep deprivation, stress, especially for knowledge workers, hunger, illness, interruptions and distractions, language and cultural factors, and hazards attitudes. This is very, very important, especially, you know, in a year where we're talking about healthcare workforce safety, where we should consider, again, we cannot talk about patient safety without acknowledging and recognizing and tackling the issues behind it, which can be related to physical and psychological harm into our healthcare workforce. So Kendall et al. In 2014 said, "We are who we are in large part because of what we remember and forget." So memory is a process of retaining and reconstructing knowledge over time. So we usually, you know, we like kind of acronyms so we can remember things. And so there is some things that we've learned also from the aviation and the military industry. And you know, so one of the things that they tell us is that, you know, for you not forget if you're hungry, angry, late, or tired, and a perform shaping factors checklist. And this one has been used immensely in the operating rooms, and you know, before people go into the operating room and the team is gathering, that we all, I mean, the team, somehow they do some sort of interiorization, and they do this checklist called "I'm safe," and basically tells you, it's for illness. You wonder, like, am I going through any sort of illness that can put me at risk of performing this procedure? Medication, am I on any sort of medication that can affect my performance? Stress, am I stressed with anything? Alcohol, am I under alcohol abuse? Fatigue, am I fatigued? Have I slept well? Am I okay? And emotion, am I going through anything in life that can affect my emotions, and how can I react throughout my work and throughout this particular procedure? Fatigue is a particular factor that we need to be alert, because it is so easy to ask a physician or a nurse just to work a couple of more hours, but please do remember that 24 hours of sleep deprivation, it's similar to having 0.1% of alcohol content in your blood. So it can be as harmful as that. In regards to the performance improvement models, I'm not really going to go through them in detail. That's not the aim of the session. But and I believe that some of you have gone through these models before. But usually we apply the PDCA model. So plan, do, check, and act. The lean model, which was developed by the Toyota production system, and the Six Sigma also approach, and simulation as well. Simulation has gone through, again, I'm just going to go quickly over these. This is not very important for the session. Simulation, as I was saying, it's becoming more and more important as we move forward. Simulation, I want you to think that it's not, so simulation is an environment where you can train without the fear of harming, okay? So you can do errors in a safe environment. And usually we think about simulation as okay, I will simulate as many times as possible so I get this right. But simulation, and this is very, probably, I don't know if it's the first time you're going to hear this, but simulation should be for training as many times as possible until you get it wrong. Because then you will learn on how to act when things go wrong. Because this is where we fail most of the time, is that we don't know how to perform when things may not go well. And this is what simulation should be all about. The picture you have here, it's about the lean management method that I was telling you earlier about the Toyota production system. So it's basically an effective approach for improving patient safety by process design that improves reliability through standard work, mitigation, and continuous improvement. This is another performance improvement model. And so safe, reliable systems share the following attributes. So they are well-defined workflows with clear roles and responsibilities. They have mistake-proofing principles to include standardization and simplification, and where needed, redundancies. Team members who share collective responsibility for one thing, safe, reliable care. Again, this is not a one-man's job. This is a culture within a whole institution that needs to be focused on safe, reliable care. This is about a bit of the simulation piece that I was telling you about. So simulation allows people to recognize problems and understand the effects of their responses in a safe environment. It's particularly helpful in preparing people for error-prone, high-risk, or unusual situations. And how can we think about integrating human factors and simulation? So we can apply the SRK framework that we mentioned earlier. And we can apply it prospectively and retrospectively. We cannot train out skills-based errors, but you can identify them through simulation and report and mitigate them as hazards. So prospective simulation, it's about using simulation-based learning experiences to identify human factor hazards, and then you debrief on them, and you don't let the hazard die in the debriefing. You mitigate if possible and have staff report them. You make it part of the simulation culture, drive the organizational safety bus. So basically is when you simulate, you don't try to build the perfect scenario. So you run the perfect procedure. It's about making it as messier, as hazard as possible, so you can learn on how to mitigate them in real situations. So example of a prospective integration case study, the CHOP co-joint twins case. So they had a simulation before the surgery actually happened, and then the actually surgery that was happening at the time. Retrospective integration, designing education-based strategies to mitigate identified risks. Often a blended approach is best. Evaluation and interaction are essential. So basically, it's when you know what the risks are and you mitigate them through simulation. The difference between the prospective is that when you do prospective simulation is you're not really sure what the hazards can be, and you're not really sure what you can encounter. So in retrospective integration, how can simulation help? So you have in situ simulations, recurrent training rule-based. So also in this situation, this can be also applied for example, defibrillator virtual training simulator. It's another example of retrospective simulation. Now, putting knowledge of human factors into practice. So again, go back to your institution and think about how you could apply human factors thinking to your work environment, how you avoid reliance on memory, how do you make things visible other than trying to hide them. Because believe me, patient safety or errors and adverse events is not something people like to talk about. People feel uncomfortable to talk about their own weaknesses. So basically it's saying, you know what, I've done a mistake, or I work in an institution that makes mistakes. Nobody likes to talk about that, nobody likes to say that, but until we recognize that it's happening, we will never be able to fix it. So we need to expose it, we need to know that it's there, we need to dissipate them so we understand them and we can prevent them. We have to review and simplify the processes you have in place, standardize common processes and procedures, routinely use checklists, and decrease reliance on vigilance. Remember that healthcare is complex. Errors are inevitable, even for experienced health professionals. There are situations that can increase the likelihood of error, okay? Recognize them for your patient's sake and yours, obviously. When things go wrong, adopting a systems approach is far more productive for patient safety than a person approach. Because again, when you're tackling a system issue, you're tackling the issue for everybody. If you just focus on a person because it's easier and it will give you the sense of, I've done my job, you're just fixing you think you're fixing a problem just on the spot. And then the mistake will happen again from somebody else. Human factors engineering is about designing the workplace and the equipment in it to accommodate for limitations of human performance and use simulation to strengthen your safety culture. Take a minute and think, how does this apply to healthcare? So a physician is writing orders on Mr. Smith, a non-urgent patient. While writing orders for antibiotics, the physician is interrupted, asked for acute pain medication order of Mrs. Connor, so another patient. The physician writes the patient medication for Mrs. Connor on Mr. Smith, whose chart was open on the computer. The nurse administers the pain medications to Mr. Smith, who had previously been given a dose of pain medication. Physician asks the nurse how Mr. Smith is doing. Nurse says, very comfortable after the second dose of pain medications. The physician replies, I never order a second dose of pain medication, and Mr. Smith is elderly and very sensitive to pain medications, and then that could harm him. They check on the patient, who requires some additional monitoring until the medication is clear from his system, and discover that the physician wrote Mrs. Connor's order for Mr. Smith. What happened? So, was this a careless physician? Did he really, did he mean to do this? What are we looking at here? Is that human behavior? Is that a drift? It is a reckless behavior. So, whenever it would be easier, right, just to go and blame the physician. But did he really mean to do this? He didn't. But what happened, right? What happened in this case? Perhaps if the system had a pop-up alert saying, this medication was just given a couple of hours ago, or something like that. Now, so this is where we would now run the practical part of the workshop, and I would be asking you to apply the Swiss cheese diagram. But so what I will do, let me just, yeah. So basically what's going to happen now, I'm going to ask Rakan to send you the link of the clip that I want you to look at. Okay, so you will do this at your own pace at home. And so you will see a clip from the Titanic movie, which I believe most of us have seen at some point in our lives. And in the clip that I'm going to show you, it's where it's the scene when the iceberg, or the ship hits the iceberg, and how the whole situation rolls after that. When they hit the iceberg, what happens, the whole drowning and the whole sinking scene. And I want you to apply the Swiss cheese diagram into the situation. So I want you to be able to tell me, what went wrong into this whole situation. Okay, so if you were to investigate everything that could have gone better and didn't go better, and think about it as if you are applying it into healthcare. Okay, so I will, Rakan will send you the clip, and we'll also send you the diagram that we need you to fulfill. And we would like to have it back by the end of tomorrow. Okay, so it doesn't need to be done by today. So if by the end of tomorrow we could have the assignments back, you can send it back to Rakan, and then we'll take it from there. Okay, thank you very much. And if you have any questions regarding this, please let me know either now or later. We're happy to take on any questions that you might have.
Thank you, Sophia. So we'll wait for the links that come in for the video and the exercise. We'll circulate it to all the participants, and hopefully by tomorrow afternoon or maybe a little later, we'll submit those. And there are no questions.
Okay,
at the
no
moment.
worries. I'm happy with to clarify any questions that can come later. It is fine. And again, as I said, the assignments can be submitted until the end of tomorrow. Okay. Okay. Thank you
All
very
right,
much.
thank
It was a
you.
pleasure. And
All right.
okay. I mean, we hope
you.
that later any other opportunity we can meet personally.
All right. Thank you very much, Sophia.
Thank
Thanks a
you.
lot.
Bye bye.